So I just want to thank you all again very much for coming. This is really exciting for me. I love what we do, and I really hope that by the end of this all, you I can inspire you to maybe think a little bit differently about how you're approaching your techniques and your patients regarding pelvic floor. So the reason why I chose coccydynia is because it's something that affects everyone, and I didn't want to have to do something like vulvodynia or prostatitis or something. I wanted something that everybody can use in clinic. So coccydynia is one of my absolute most favorite things to treat, and it's a very effective treatment what I do, and it's very simple, and it's effective, and it works. And so I want to talk to you about the most recent patient that I had who came in with coccydynia. So we'll go ahead and get started. So the objectives of the presentation today are, number one, to have fun. You're in clinic all day, and if you aren't having fun, it can be a drag. So working, as you can see here, working with pelvic floor disorders, it can be a real burden on your shoulders, because the patients who are coming in your door have been seen by multiple practitioners over the course of many years, and they come to you and they're still in pain. And I just sit down with them, listen to their story, and do the best that I can do every time they come in the door. The second thing is helping to educate your patients as to the why they're feeling the way that they feel, and to let them know you can make a positive impact. I have been doing pelvic floor work since 2009. And so many people come to me and say, I didn't know I had a pelvic floor. What is a pelvic floor? So I take great joy in actually showing them my Essential Anatomy app, any kind of charts that I have, and explain to them the importance of the pelvic floor and why they're feeling what they're feeling. The third objective is to learn how you can immediately and effectively treat their musculoskeletal issues using extremely simple techniques. And the fourth thing is be open-minded about the new treatment techniques. Sometimes something very simple works very elegantly, and sometimes you need to take it up a notch. So we're going to talk about that. Okay. I'm trying to advance to the next slide, and it's not advanced. Oops, sorry. Okay, sorry about that. So let's jump in with the what. The what here is the coccyx, and I think it's pretty funny because it means beak of a cuckoo bird. I'm a big birder myself, so I'm not a big fan of the cuckoo bird. They're a parasitic bird. They lay their eggs in other birds' nests. The cuckoo hatchling hatches and pushes the eggs out. So not quite fond of that, but we'll just, it is what it is. It is the terminal region of the vertebral column, and it consists of 3 to 5 vertebral bodies that articulate at that sacrococcygeal ligament. When you gain access to the coccyx, you can actually gain access to the levator ani group, and you can treat many issues here, which is very important, and we're certainly going to be practicing and covering this in Tampa in March. So the when is this, the when is simple. Anytime a patient comes to you and has pain. And just to talk about this, so when you're in clinic, it can be anything, right? I'm sure you've seen just about everything. I've seen just about everything. But what we're going to focus on today is 2 primary groups that present in clinic. So direct trauma to the coccyx, and this is going to include anything from vaginal childbirth, vertical impact, repetitive microtrauma, surgical interventions, and trophic changes, adhesions along the pelvic floor and diaphragm. So the case study that we're going to talk about today is actually an equestrian. So pretty serious injury. So we're going to actually talk about the direct trauma in a minute. The second one is systemic illnesses. So these are gastrointestinal disorders, urogenital disorders, and this can include musculoskeletal as well, but here we're talking about malignancies, Crohn's, interstitial cystitis, infections, lumbar disc prolapse. and you want to be able to differentiate between the two. And sometimes it's not that simple. Most of the time, it's not that simple. There's always some comorbidities for sure. The where is um, this particular case study directly in the coccyx region. So we're doing osteoneedling, osteopecking, periosteum pecking, ligamentous needling, perineal needling. It's not just Ren and Do, and anything in that pelvic diaphragm. So levator ani, we're dealing with erector spinae, glutes, etc. in this particular case. Why? Because we can. We are licensed in this amazing field of medicine. We literally manipulate soft tissue. And you're going to hear me say this all the time because I've met so much resistance with people who say, oh, well, my pain management doctor doesn't recommend acupuncture or dry needling because there's not enough research on it. I'm going to tell you right now, there is no placebo effect when you're causing fasciculations of glutes, when you're causing fasciculations of levator ani. You are directly impacting and changing those muscle spindle fibers immediately. It's very obvious. The patient feels it right away, and they will get off the table and say, I absolutely feel looser. I feel like there's more space. It's not as painful. I can sit more comfortably. All of these qualifying factors that you are helping them with. And that's another thing I love to talk about, just the education as why it's happening, what their expectations are as far as, what they're going to feel, immediately afterwards, 1 day after, 2 days after, so forth and so on. So the how is this dynamic and effective needling technique that directly manipulates and changes the pelvic floor. And my immediate goal for you is to start to incorporate this type of work to help produce substantial changes with better clinical outcomes. Just a little bit of background about myself. I know that we've all been in the trenches. I've been in clinical practice for 20 plus years. I graduated from the American College of Traditional Chinese Medicine in 2008. My clinical doctorate is in pain and women's primary care. I didn't have a choice when I went through the program. It was the first professional clinical doctorate at ACTCM. We had to do both. And so I kind of just fell into it. It was just this natural thing that occurred in 2009. Because of successful musculoskeletal outcomes working with patients and finding out that they were having these issues that they weren't talking about in clinic because I was treating them for cervicalgia or I was treating them for, radiculopathy. They were embarrassed to talk about it and they weren't seeing results. And so it came to my attention that, hey, if I can help and be successful doing these other musculoskeletal things, what is that going to look like in the pelvic floor? So I studied day and night. I just, netters was seared into my mind. Literally, I would wake up in the middle of the night thinking, oh my God, I can see every single muscle in the vagina. This is incredible. This is what I need to do. And just having patients willing to want to get better. I think that was the big turning point. They were determined to feel better. I wanted to do my job effectively and efficiently and developed a very simple protocol to use. I have a clinic in a very saturated market here in the Bay Area. But let me tell you this, people need you. They need you. They want you. They will seek you out. If you learn how to do this, if you learn this technique, you will hit the ground running and you will start seeing it in clinic immediately. There is a serious lack of specialists who treat pelvic floor. I mean, even in the physical therapy world, just recently, in the last few years, the 3 most prominent urologists here in the Bay Area have actually retired. So there's no one to refer to now as far as like, we're not going to talk about pudendal nerve entrapment and neuralgia right now, but to do injections, there's just no one to do it. So you can help them, and it's really remarkable. And having that relationship, gaining the trust, it's a very, very special relationship that you develop with your patients when you can help them with something that's been plaguing them and embarrassing them, and that they think that there's something wrong with them, that sex is just naturally painful, or bowel movements are painful, or oh, I just thought that this was a side effect of menopause. I mean, these are all the things that I hear every single day, and it's just simply not true. So helping them, doing this, you're really going to boost up your practice. I love what I do. I love teaching. I've taught here in the Bay Area. I've done mentorships. I worked at Highland Hospital for 5 years. I taught medical residents in the outpatient adult clinic for pain. And I just love it. So, and the training, this is a good one. I get asked this all the time. I have people reach out to me all the time asking me, where did you do your training? Well, I did my training through motor point work, dry needling, electroacupuncture, soft tissue manipulation, visceral work, trigger point work, osteopuncture, neuropuncture. I mean, it's all about just incorporating this, really, as Josh said, this renaissance time that we're in, just taking what you're passionate about and like wrapping it up into this amazing package, and using everything that you have for your patient. And we're going to be doing all of these things in the upcoming class in Tampa, because I really, the needle is an extremely powerful tool. Just at the very most basic level, you're perfusing soft tissue, allowing oxygenated blood to get into that tissue that's become, ischemic and fibrotic. And the body is actually going to heal itself. It's going to get better faster if you do that. So everybody needs this. Everybody needs this. Everybody needs us. And it's just super rewarding. Okay, so this is the fun part. My case study, the initial visit was December 15th, 2021. 54-year-old female presented. She was a pelvic floor physical therapy referral from very far away, from Northern California. Acute coccydynia from direct high velocity kick from a horse since September of 2019. 10 out of 10 pain with certain motions, 5 to 7 out of 10 when not a 10 out of 10. So all the other times she was a 5 to 7 out of 10. The story goes like this. She told me she had the best day of her life. She was out riding her horse and just was so happy and so full of joy that she dismounted and was walking with her horse in the field. And the horse, I guess yellow jackets are nasty little buggers. The horse actually stepped on a nest of yellow jackets and started bucking and hit her square on the sacrum coccyx region, throwing her. And she actually had over 100 yellow jackets stings, in addition to this acute high velocity trauma to her sacral region. She said then her best day went to her absolute worst day in a matter of seconds. She has extreme pain all of the time, sitting and standing. Now that's unusual, because most people who have coccydynia or pudendal neuralgia present with sitting is the exacerbating factor and triggers the pain. She did have pain whilst lying in bed as well, waking her up. So her sleep was getting really disrupted. She was very stiff and kind of, in her motions, she was very calculated with these small little micro movements when she was in my clinic. Coughing and sneezing aggravated the pain actually quite a bit. And to quote her, she said that she felt constant, sharp, shocking, stabbing, and ripping pain. So there we've got, we've got nerve pain, we've got, muscle, spindle fiber issues, We've got bone pain. So all of these things tell me, oh my goodness, like we got to do everything. It had impacted her genitouretal functions. So she was having pain with bowel movement, also pain with urination, and you see that actually, it's all interconnected. That pelvic sling holds up that abdominal canister. So very, very oftentimes there's GI and genitouretal impact due to trauma here. And obviously pain with intercourse. Radiograph showed impact of that sacroiliac joint with a subluxation and angulation. And I actually forgot to write it down, but I always would have her side lying and recumbent with her right side up. The angulation was, the coccyx was up. So if this is the coccyx, and if you're looking here straight onto her coccyx, it was subluxed and up to the right. She was seeing both initially a regular PT and her pelvic floor PT since fall of 2019. So this had happened in September and wasn't getting any better. And so that's when the pelvic floor PT was like, you know what, you need to go see Jamie. I've done all I can do here. So if I could have been an immediate intervention, I know that she would not have had to have waited that long to get the results. I'm huge into collaboration. I don't believe in competition. I think that and you'll see this, and we'll talk a lot about this in Tampa, when you're treating patients with pelvic floor disorder, because they are so chronic and long-standing and have seen, on average 5 to 8 practitioners with a time span of, 3 to 5 plus years, it is a truly patient-centric, radical, revolutionary approach where you want to have your patient at the very center of the table with all of their healthcare team. If that would have been the case, I know we could have saved her, and she wouldn't have had to have been suffering for so long. Right. So physical exam, again, lateral recumbent, it revealed she had hemangiomas all over her lower 1/3 of the sacrum and swelling. Visually, we're dealing with trophic changes, vascular changes to the immediate area. I mean, very, very light palpation, very, very light. She was like, ow, 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 like screaming on the table. So, if you just barely touch your hands, that was the pressure that I was doing. I palpated her glute attachments. I palpated the iliococcygeus, which we got a strong positive. The anococcygeal ligament was the strongest positive. Again, very, very light pressure. And her lower sacral foramen also were very, very positive for even more, tender spots. She had right side QL shortening in addition to hip hiking. So this was what I was thinking. At this point, after having, I saw her paperwork before she came in. I always send out the paperwork and have a look before the patient comes in. And then I actually want to observe them sitting, standing, walking in the door. What is the color, like their skin tone? Are they gray because they're in so much pain? Are they shaking? Are there tremors? But I only had about 20 minutes left of the treatment. So all of my treatments are 50 minutes long. So that's 50. So I just wanted to dive right on in and do what I thought would make the most impact on her. So this is what I did based on the exam. Worked the superficial fascial border of the lower sacrum and coccyx, worked the anococcygeal ligament, worked the gluteal attachments along the sacral border. I did the lower sacral foramen and the iliococcygeus. Now my technique is great because it's something that you can pepper into your own treatments. So if you love to practice classical acupuncture, you can do this very, very quick work at the beginning and then do your pulse and tongue diagnosis, put the needles in, or you can do your pulse and tongue diagnosis however you decide to treat, and then do this at the end. I focus solely on the soft tissue and do whatever it takes the entire time the patient's there. So that's just how I prefer to work. And it's, patients always say, "Oh, I don't get a nap." I always think that's really funny. I'm like, "Yeah, no, you never rest with me. Never, never." So just one thing to keep in mind, we're not going to cover the consent because that is a big part of working in the pelvic floor, but I'm totally going to go over it in Tampa. I'm going to actually give you all the attendees in Tampa my informed consent specifically for pelvic floor. We're going to go over draping, appropriate language, appropriate touch. But one thing you need to know working in the pelvic floor right now is you need to be communicating and clear at all times with your patient, and always give them an out, and always give them a roadmap. This is that that essential anatomy app or your diagrams that tell them this is where we're going to go. We're going to go into, the coccygeus. We're going to go into your levator ani. We're going to go into your anococcygeal ligament. Are you okay with that? And patients, I've never had a patient say no, ever. So, but they love it when you can show them, because a lot of times, again, I'm just going to say this, they'll come to you and they'll say, well, I've had all this imaging and they say that there's nothing wrong with me, but it hurts. And another thing that I ask them to do too is if they're able to reach around, like, show me where it hurts. Like, I want to touch there. I want to see. And then I confirm, like, absolutely, I can feel that you've got fascial adhesions here. So let's break those up. So after the treatment was over, she immediately reported that she felt sore in a really good way and that she felt looser, and surprised that it wasn't that bad. She's just a really lovely lady. We hit it off right away. It's important that when you're doing something so intimate and working in such an intimate region, that you gain trust right away. You find that common ground. You are the person that is going to help them feel better. The techniques that we utilized were myofascial trigger point dry needling. ACE Seminars and I are collaborating on a class for this upcoming fall just to do that, which I think it's going to be so much fun. We also did ligamentous needling and deep sacral foramen needling. So one of the things that we're going to do in Tampa, and I'm just so stoked about this, we're going to actually do a lot of deep needling. I know so many people are, acupuncture schools scare you to death. Oh, don't needle stomach 36 with anything, heavier gauge than, I don't know, like a red serin. I was told that one time. I'm like, are you kidding me? Like, I want to get a sensation there in that anterior tibialis. That's a really important point on the anterior tibialis. So we're going to do a lot of needling and all different kinds of tissue. I tell my patients, on a scale, you've got super, super squishy tissue like your skin, all the way to, skeletal tissue, right? Bone. You can needle on that whole spectrum. So we're going to needle on that whole spectrum. We're going to go squishy to bone, ligament, tendon, cartilage, joint capsules, muscle. It's really, really incredible. And I'm super excited. And we're going to have all different lengths, gauges, so you can practice that. And for the sake of also too talking about pelvic floor right now, it is not a one size fits all with needles, which a lot of my PT friends who have taken dry needling classes elsewhere have said to me, oh, they only have this one size needle. And I'm like, oh, that's just rude. Like, you don't want a big fat needle in somebody's masseter. You're going to give them a big old bruise. Like, you don't need to do that. You can get a good fasciculation with an appropriate gauge needle, an appropriate length needle. Right, so this was the slide here. So it's not a one size fits all needle technique, but there will be some orthopedic style of needling that many may not be familiar with. This is why in the pelvic floor seminar, we go over a lot of this in the hands-on portion. For this particular case, these are the needles that I use. I use DBC because I use a lot of needles. I know a lot of practitioners who they pride themselves on only using, 1 to 10 needles per treatment. That's not how I work. I don't do reinsertions, so I use a lot of needles. I can use anywhere from like 20 to 50 needles per treatment, depending upon what we're doing. For example, if you're needling in the external anal sphincter, you are gonna get the fasciculation that you need, withdraw, feel that you got the trigger point, and then get another needle. So, you're going to use as many needles as you want until you fatigue that muscle. But specifically for her, I used the 50 millimeter thicker gauge in the sacral foramen because you have to go through that fascial sheath. The anococcygeal ligament, I do like to use a little bit of a thinner needle here, so that 0.25 by 30. And if you wanted to access, the deeper muscles into the levator ani, you would use a longer needle, of course, because they're deeper. The fascial needling of the glute attachments, it really depends upon what you're treating. So, for example, I have quite a few pudendal neuralgia patients right now who are cyclists, and the fascia around, I know we're not talking about pudendal neuralgia, but the fascia around that, the sacrotuberous ligaments and the attachments on the glutes, it feels like stale marshmallows, and it shouldn't feel like that. So you need a thicker needle to really break up those adhesions. But for her case, it was 0.25. 0.25 was efficient. And that iliococcygeus, again, you need a little bit longer needle because you need to be able to get to that. So, but you don't need a thick one because it's in the pelvic floor. Additional patient care on first visit. I always add soft tissue work. I call it nice, nice. I've called it that forever. It helps patients, you kind of go in and smooth everything out, and it diffuses the micro trauma that you have deliberately caused to that area. Um, I love this. It's called Paint Away. I buy it locally. One of my very dear friends here in Sonoma County makes it. You know, she sells it. It's a CBD THC oil, but it also has, like sun lung, ju. So those kind of, that jiao, jianggu shui herbs for the moving the stagnation, so to speak. Tongzi butong, butongzi tong, or however. It's been a long time since I've said that, so can't exactly remember how to say it, but it's in that. People love it. And I also give patients instructions to continue, well, at home, but specifically for her, to use her cushion, to take a walk afterwards to encourage and incorporate the new soft tissue normal. So that is neuromuscular reeducation. When you reset muscle spindle fibers, you don't want them to have an opportunity to become contracted again. So when you do gentle movements and stretches, you are directly impacting that neuromuscular reeducation and that pattern that, it actually is more normal. And moist heat. Moist heat is great. I love those really old school hot water bottles. You can get them on Amazon. I think they're like $20. They're that red rubber, and it says, they have the screw top. They look like from the cartoons. They say, don't put boiling water in. Well, put just below boiling water, but you want to vent the steam so it doesn't blow up on you, and you don't need to fill it up. And you can put it on the spot right away until you can't handle it anymore, and then put it back, take it off until it becomes manageable, and you can leave it on for like 5 to 10 minutes. And it's great too because they can I have a lot of mega commuters who drive in from all over Northern California and actually Southern California. So it's great. They can just take a hot water bottle with them and fill it up as needed in the car. Okay, so her second visit was on December 28th. Patient reported no tailbone pain for 2 straight days, so a 0 to 10 out of pain. And this was coming from a 7 to 10 out of pain constantly, up to a 10 out of 10 pain. She did report that the sensation, the pain gradually came back on the 3rd day. She was extremely excited to have 2 days of complete relief, and that she was happy and yet a little disappointed that she didn't come in earlier. And you'll get that a lot. People get really upset actually, and they write nasty letters to their pain management doctors and whatnot. When she sneezes and coughs, the sensation now, she said, is like a tug on a rubber band. She noticed that her bowel movements were easier and not impacted as much, which is fantastic. She still had some urinary urgency, but it was a lot better. And she was so impressed. She was like, "Oh yeah, my upper mid thoracic, issue." Like she pointed, "It hurts, and I have a hard time, backing my car out. Can you help me? I know it was so helpful before." I said, "Yeah, it's fine, no problem. You do what you can do." And I honestly didn't do any physical exam there. I just palpated and said, "Where does it hurt?" And she was like, "Ow, ow, ow," and I'm like, "Okay, that's where we're going." But the physical exam revealed much less swelling in the sacral region, and soft tissue had more spring upon palpating, which is super important because you're, again, perfusing the area. You're getting, that rich blood flow in there. It's feeding the tissue, it's healing the tissue, it's moving out all of those inflammatory markers that have been kind of stuck there. They've just been stuck, accumulating, causing pain. Soft tissue work. Again, afterwards, we did CBD, THC. Oh, here, I'm so sorry. I skipped a slide. So the follow-up treatment, that second visit, I tell all my patients, they always ask me when I'm screening them on the phone, how many treatments am I going to need? Well, I have no clue. I have no clue. So I tell them the second visit, let's schedule it within a week so you remember, it's fresh in your mind. It's always our data point. So based on whatever their report is, that's what we need to do, right? So we jumped in, hit the ground running that second treatment. So 40 minutes of soft tissue work. I used the same needles, similar to the initial visit, but I did SI joint needling. I did that just because she was getting, she kind of felt like it was stuck a little bit. So I said, okay, that's fine. Well, no problem. I don't know that we're covering that in Tampa, but for anybody who doesn't know how to do that, it's a lot of fun. It's really easy. I'll certainly be happy to show you. So, but SI joint needling here to free up any tension coming from that joint that was contributing to the issues. We did her sacrotuberous ligament, which was fun. We did get some positives on that one. And again, the sacral foramen. We added bilateral quadratus lumborum. We did the erector spinae at that lumbopelvic junction. You get amazing results, even just in low back pain with needling through there. I did trigger point releases on the glute max, piriformis, coccygeus, iliococcygeus, all along the ischial-rami through the posterior outlet, so that's towards the back. And again, I hit her upper trap trigger points because she just loved it so much. We did fascial needling around the coccyx and osteopecking on the coccyx as well. And let's see if we are, and then I think the next slide was what I said just to do, right? So soft tissue work with CBD, THC. So I was told, I don't know how much y'all know about CBD. I'm kind of new to the game. I've been using it in clinic for about 3 or 4 years, but it does have to have some small amount of THC to help with pain. So I got a text from her, which I thought was really, really nice, 2 days after the second treatment. So back and shoulder area was a good sore on Wednesday. I can actually turn to see when I'm backing up the car. Lower back is much better, but it hurts in certain positions and no tailbone pain since my session. I'm peeing less often and more manageable sense of urgency. Huge improvement, life-changing, thank you. I tell my patients when they're enrolled with me that they can reach out at any time. They just have oftentimes felt abandoned by their other practitioners. And so it's just a nice little way that I like to connect with them. So her third treatment was on January the 7th. This was her third treatment over 3 weeks. So 0 out of 10 pain. She did say that this 95% gone. It was the 5% was the very slight tugging sensation. Low back and mid back so much better. Extremely happy with treatments. We discussed her getting reassessed by her pelvic floor PT and only coming back as needed. But they're hooked by then. They're like, if you can fix this, that's been a thorn in my side and a pain in my ass for 2 years. You have got them. They will come to you for everything. We did this third treatment, left QL trigger point release. fascial releases of residual and anococcygeal ligament, sacrococcyx soft tissue releases, and gluteal attachments. The needles were the same. I did the same soft tissue work with the CBD THC. If you want the name of that oil, you can email me. I can put my email in the chat, and I can hook you up with the woman who makes it. It's all my patients really love it. So this was a huge win for the both of us. With just 2 treatments and a third to solidify results, we achieved our objectives. One thing that I like to tell my patients when they do call is that not all acupuncture is the same, but it's all very helpful. So I like to tell them there's all different styles of acupuncture, you know, but this particular type of acupuncture is very hands-on, very to the point, very, very laser beam focused, and it works. So by adding some quick technical musculoskeletal work, you can achieve these very good results extremely fast. The pelvic floor sling, you know, it's an important complex because it supports the abdominal canister, so all the viscera, all the fascia. Again, 65% of your body weight is distributed through that pelvic floor. And so anytime you have pain, it needs to be addressed as soon as possible. So not overthinking what needs to be addressed. I'm not one of those people who, you know, researches I don't know, the Ling Shu looking, oh, what did they do? I just kind of say, I think I know what you need, you know, let's get into this. I tell all my patients it's not magic, it's not mysterious. A few good placed needles and manipulation can make a huge world of difference. And it's important to know when to refer out. So that I had to throw in there because we did talk about, you know, malignancies, gastrointestinal disorders, you know, cysts, for example, things like that. So, but you can still make a huge impact by doing this type of work. And that's it. So I want to thank you all so much. I have so much to teach. I don't even know where to start. I feel like that crazy professor. I mean, it just, my house is blown up with, you know, musculoskeletal books and anatomy books and, you know, clinical books on, you know, the urogenital region. It's just, this is what I do. This is my love. This is my life. And I don't want anybody to feel like that you can't approach me, because guess what? There's so few that do this type of work. We need to have an army. We need to have a revolution. We need to really, really get to this like foundation. And this is how it's going to happen. This I am convinced is how it's going to happen. So feel free to reach out, and I'm happy to answer any questions y'all have. I am going to ask Josh to jump back on because I don't know how we're doing, like where the questions are, but please feel free to ask. Nothing is off limits. You can ask me anything. I will be candid with you. I think it's so special, the position that I'm in, and it's such an honor actually, because I've just had to figure this out for, you know, over a decade on my own, and it's all been clinical and it's all been trial and error, but now I feel like I know what to do. So, and I want to save you all from trying to feel like you've been thrown out to sea, and I'm just going to help you all I can. So here we go.
Yeah, that was just awesome. I love this particular specialty. It really shows the power. Well, a couple of things. It exemplifies the problems that exist, that we know exist, right, in the
Totally.
conventional care of patients. But it's almost like magnified with this, because the degree of debilitation and disability that this causes, coupled with the lack of conventional medical care and being thrown into the typical, you know, circle, you know, PT, which is great. Okay, PT works fine. PT for 2 years, not necessary. That's ridiculous. Injections, if you can find somebody, but they're limited as well. This is
That's
really
right.
like soft tissue assessment, palpation, really getting into these spots. Who can do that? Acupuncturists can.
Acupuncturists can. And, I got to tell you, I have so many PT friends and I adore all of them.
Mhm.
But the thing that I really love is they tell me, like, this is not my wheelhouse. I'm a pelvic floor PT, but you're the pelvic floor musculoskeletal wizard. Like, this is what you do. And I can't do what Jamie does. They tell all of their patients, you need to go, you need to go see Jamie. And the thing is, it's a collaboration. I have them all on text. And I will literally be like, thank you for the referral. What were your findings? How can I help support you and your treatments with them? And they come back right back to me and say, oh, I want you to do this, can you let me know how it goes? And the patients are reporting back, I'm reporting back, so it's this like positive feedback. It's really fantastic.
Yeah, and it's not to put anyone, like, plenty of acupuncturists, every modality or every specialty has this issue where we just hang on to patients much longer than we should.
And that is not okay with me. I had a patient the other day say, is this going to be 12 months? Am I going to come for 20 treatments? And I just laughed. I said, you need to fire me if you're not better. Like, I would never do that to you. Like, that's just not okay with me. If you can't help them, you really need to get them to where they need to be.
Yeah, and help has different meanings, whether it's getting somebody through because they can't retire from their job, so you're just trying to keep them going because they keep re-aggravating it. Whether or not but if they've plateaued and are not getting any better, then it's okay to refer out, and it's okay to refer out to other acupuncturists too.
Absolutely. And I have done that. And on my intake form, it says, who is your acupuncturist? Who is your chiropractor? Who's your PT? Who's your primary? And they say, well, should I still go to my acupuncturist? I said, absolutely. What are they treating you for? 90% of women who have pelvic floor disorder have, again, gastrointestinal involvement. So there's some type of IBS, there's some type of, I see there's something else going on. So I'm like, you go to them for that. I'm
Mhm.
just going to manipulate as much as I can, as quickly as I can, to help you most efficiently as I can.
And I want to ask one quick question, and then we can get into the Q&A. By the way, if anybody has questions, please put them in Q&A. I did see one in chat. We'll get to that one as well. I caught it. But what was it? Let me think. Oh, the needling. It's all. Do you do any retention of needles at all, or is it just
No,
no? Okay.
I don't. I I joke around. I had a patient the other day. He's a very athletic gentleman who's retired, and he chases snow. He's a huge skier. And anyway, you've all seen this person. He's had like hip replacements and ACL surgeries and hernia repairs, and he's very tall. He's like 6'7". And anyway, he has an owie spot that he put his leg up on my table, and he's standing on the floor and he puts his leg up on the table and he goes, it hurts right here. And I literally got underneath him and I said, God, I feel like I'm changing your oil. It's like you just go in, you assess the tissue, you do the fascial releases, the muscle releases, whatever it is that you need to do, and you get out and you move on, and then you can check the bigger muscles. With him, it's he's got some issues with hamstrings and things like that. So just like releasing hamstrings, doing motor point work on the hamstrings, whatever.
First question is.
Okay, so what do the pelvic floor PTs in your state do? Okay, so that's a good question. So, California is one of the holdouts for needling. It is they're not allowed to do it, and I get a lot of patients who come in from out of state who are like, "Oh, my PT did this and it was really helpful," and then they get upset because they're like, my PT here can't do it, so they referred me to you. And I let them know, well, this is actually my wheelhouse, this is what we do. And then as far as what they do, I always try and have a good relationship with all the PTs because it is a collaboration with the pelvic floor. there's a lot of stuff going on down there. And so all my PTs kind of are at different levels. Like I have some PTs who are movement specialists who work in the pelvic floor. I have some PTs who very specifically work around sexual dysfunction. So depending upon where they come, who refers them, but they'll tell me like, I really want you to needle that, I don't know, the transverse perineum. I get that a lot. And then they'll always say, oh my God, like, this is amazing. I had a woman who, I think I told you this, Josh. She had a pretty gnarly episiotomy scar. I mean, really, really gnarly. And she's gone to her I told you this. She went to her pelvic floor therapist for 90 visits out of pocket to work on the scar because it was causing her so much pain. And I saw her the one time. I mean, I've obviously gained her trust after that one visit, but this pelvic floor PT has been sending me patients over the years, and I was surprised she actually didn't send her to me initially when she had the scar when it had healed up. But my patient said that she got more out of that one visit with me than all 90 visits with her PT. So there's a lot that they can't do that we do really, really well, and so. But I never come from a place of, oh, well, you should have sent them to me. It's like, oh, well, I'm glad that you're noticing a big difference in how the scar is moving and what it's tugging on, what it's fastened to and things like that. So the second part of that is, what do they typically work on? Everything. They do, IC, pedental neuralgia, they do ED, I particularly see a lot of hernial repair. Well, I'm not going to talk about that, but I see a ton of that. And they do internal work, but here's the kicker. You don't need to do internal work because you are already going externally to internally through the different layers, right? So you don't need to do any actual rectal exam. You don't need to do any vaginal exam. We're not going to cover this in Tampa because I want y'all to have a little bit more practice before you needle into that labia minoris and the vaginal fourchette and around that vestibule. But you can do that. But again, do not do it without me showing you how to do it and getting trained first. But they do a lot of the reports, and then I get to see the reports and say, okay, I can totally get to that. Okay, so hopefully that answered your question. And then let's see here. And oh, everybody's so sweet saying thank you. You're all welcome. Okay, contact pain cream. Oh, thanks, Josh, for putting my name up in there. Were there any other questions? Okay, curious about the position of the patient to put the needles in. That really depends on what you're treating. So we're going to go over that in Tampa because you could really hurt yourself and your patient if you haven't positioned them properly. So one thing that, like with tailbone pain, for example, and depending upon the size of your patient, I always have them in a lateral recumbent, so side lying position. And depending upon where I'm finding the most positive spots, like the most provocative spots, I'll actually have the patient assist me by holding up their glutes. They'll pull the glutes out of the way so I don't have to be peeling them up against gravity and then, needling them. So I hope that answers your question. We'll definitely go over that. That's also part of the draping. It's a part of the draping at the Tampa seminar. Oh, Catherine just asked a question too. She just says, do you have patients remove their underwear? Absolutely. I mean, I have a whole very, how do you say it, streamlined protocol for draping and everything. Like you don't want to be fussing around with a lot of fabric. I always ask my patients though, for example, oh, I'm on my menstrual cycle. I have a tampon and a pad. Are you okay with that? Well, there are totally ways around that. And we'll talk about that in Tampa. Tracy asks, what exactly is the March seminar? Tracy, if you're still here, hello. Thank you for the question. So what we're going to cover in Tampa is something that you can use in your clinic for any patient that has a pelvic floor. So I didn't want to make it, gynecological versus like androgyny. I wanted to really just do stuff that everybody has issues with. So we're covering I think we're covering levator ani syndrome, bladder pain, scar. I'd have to look, but there's like, oh, thanks for putting that up there, Josh. Josh just put the outline up.
But we do have some questions in Q&A, but we have one more in chat, and then we're going to move to the Q&A. Jamie,
Okay, so
yeah.
what's the one in the last one in the chat?
Do you have a staff member or a witness in the room?
Oh,
Do you feel fine with that one?
no, I don't. And let me explain. So I put that on the patient. You know, you want to empower your patient at all times. They can always say no, and you let them know that. So in my consent form, it's very clear about having a chaperone, and we'll go over that in Tampa. Again, I'm very, very happy to share my consent form with the attendees in Tampa. I paid a lot of money for it, but it's pretty ironclad. And but let me just say this: I've never ever had anybody um, feel uncomfortable or asked to have a staff member or a family member or whomever in the treatment room. Not one time, and I've been doing this since 2009.
Okay, Jamie, do you want to hop over to Q&A?
Yeah, sounds good. So I'm going to close up this chat and then Q&A. Okay.
Can you see?
Colin, how are you, my friend from the Great North? Um, so Colin's asking the percentage of female versus male. I see a very good 50-50. It is very, and let me tell you, my guys, they are so shy. They are so lovely. The women literally will start taking their clothes off like while you're talking to them. They'll just start taking their underpants off. I'm like, wait a minute, like let me give you a drape. I'm gonna step out of the room. My guys though, they're so polite, they're so respectful. I see a lot of, again, pudendal ED, hernial repair. Um, oh gosh, I mean, yeah, Coccydynia. These are just some things off the top of my head, but I would say definitely half and half. Tracy, are you doing 50 minutes on each one time, each treatment? Are you going up? Oh, so I got burned out doing multiple rooms. I had a several room clinic for a very long time, from 2009 until 2017. I was running a 4+ overflow room clinic, and I was doing myofascial work. I was doing all the like nitty gritty really fast, what we talked about in the Coccydynia, and then I would just throw some stuff in, put some heat on, let them bake. So that is a very good way to treat patients. But I got really tired, and so I choose to only do one person at a time. But you can do it, and we can talk about that. And I'm happy, you know, what I do, anybody can do as long as you're willing to commit, go there, do it, learn the technique. Like, yeah, you can totally do that. Dennis, thank you, Dennis. Good to see you here. Jackie, okay, I've been treating a lady for a few months with urgent stress incontinence since childhood, treating her distal point, Swato Jaji, not much improvement. Okay. She wants me to continue trying, but I don't want to get to the end of 20 treatments. Okay. Jackie, so this is an interesting one. A lot of my patients who have, you know, stress incontinence and also urge incontinence, there's definitely some psychological component to it because they're always looking for the nearest bathroom. They're like petrified that they're going to have an urge and have to go pee, and they'll have an accident. So this is definitely a multifaceted approach where they definitely need to be seen by you and a pelvic floor physical therapist and possibly a therapist that works with pelvic floor. I would have to see kind of how she presents to offer you some advice, but I will tell you, we are going to cover bladder issues in the Tampa class. And one thing that works really, really well and I'm just going to tell you all this is a free nugget, guys, is that the bladder ligament, the umbilical ligament actually attaches to the fundus of the bladder. So if you palpate for that, and this is that deep needling technique that I'm talking about, you got to go deep. So don't be afraid. You got to do it. But if you can palpate that and you can palpate that fundus of the bladder, you can actually release the ligament, and it's amazing. Like you'll see their whole abdomen shake and they'll feel it, and then they'll be like, oh my God, I don't have to pee anymore. So yeah, so I would suggest that you maybe do that. Okay, so been doing electron spleen 6. Okay, so that's that posterior tibial nerve stimulation that everybody's jumping on that bandwagon. Um, Look, if you've seen her 20 times and you've been doing electrostim on, spleen 6, the other point to that is actually approximately kidney 3 to 7. So you have to palpate that nerve down there and hook that up as well. So try that. And Colin asks, follow up. I think the perception about a female working on a male would be looked at as more acceptable than a male working on a female. So what are your thoughts about that? Colin, I'm going to tell you a little story. Um, I work with the godfather of pelvic floor physical therapy, who is trained by Travell and Simons, and he refers patients to me. And I got to tell you, he's impossible to get into. It's a 3-month wait list. And yet, I'm honored. He trusts me and sends his patients to me, and I talk to him all the time. So there's definitely a need for it. I think that when your patients are suffering the way that they do, and again, I mean, this is a different level of suffering, like 90 visits and the patient isn't getting better, 2 years and the patient isn't getting better. Like if you can help them see that you can make a difference in 1 or 2 treatments, they're not going to care, if you're a dinosaur. Like they're totally going to be on board with you just helping them feel better. So I do think that there is a huge need for male pelvic floor work, because my guys are so shy with me. But I love people. I'm good at like breaking ice, and so they trust me. We have a good laugh. It's a lot of fun. I always try and make it fun. But I know that they're probably withholding some things. It comes out 3 or 4 treatments later that, their erection isn't as hard as what they want it to be. I had a guy the other day tell me that after I worked on him, very nice elderly gentleman, he said that his pee stream, he could like shoot it to the wall. And he was like 5 feet away from the wall. I was like, wow, why didn't you tell me that you felt you had a weak urination, like your stream was weak? And he was like, well, I just felt embarrassed. So I think that, he would feel more comfortable if I were to be a guy. But it did come out, and I told him, I said, that's fantastic. I'm glad that you're, everything's going better. So, and then it looks like Sharon. Hi, Sharon.
Oh,
I love seeing you guys here so much. It's oh my gosh, what a treat. Sharon asks, oh, patient with PN, a gyne specialist, nerve injections, right? So that's the thing. The pudendal nerve has 3 branches, and so which branch is it, and are they all lit up? Like, yeah, pudendal neuralgia, we're not going to talk about in Tampa. This is an advanced needling class for sure, and it's one of those things that you're not going to make a huge difference like right away. This is one of those um, uh, um, issues where people, it takes time for them to calm the nerve down. When your nerve is being cranked on and compressed, like it takes we talk about that, neuropraxia, right? Like there's no oxygenation to the nerve. There's and it's just lit up. So the whole thing with pudendal neuralgias is, if this is the nerve here and this is the tissue around it, you want to make that tissue so the nerve has a pathway so it can glide, so it can floss, right? So there's space in that outlet so it's not getting compressed. We do that really, really well. And this is a good point too with the people here who do distal work. One of my very good friends at University of California, San Francisco pelvic floor clinic, she'll do fascial manipulations distally, just like you would do your, tan and tongue and points distally to help kind of just get that pain flushing out of that area. So, okay, since I'm unfamiliar with your technique, could distal acupuncture work? You can try it, but you really need to like get into that bee's nest. You really got to do that. So, and any suggestions for someone not versed in your style at the moment? So I would definitely. So the thing with pudendal neuralgia, Sharon, is that the pudendal nerve comes out at that lower one third of the sacral border, and that it follows that pathway and it wraps around. So the first branch is the rectal branch, second branch is that perineal branch, and the third branch is the genital branch. So you could work distally in the pudendal nerve. So, for example, if they have problems with the rectal branch, you could either work higher up on that line, so around that lower one third of the sacral border, or you could try going into, I don't know acupuncture points anymore because I just write the names of the muscles down. But you could work kind of like towards that fourchette, or towards the bulbospongiosis, just to kind of connect it wherever that pain is. So you want to find where the pain is in the middle, right? And get kind of on the poles is what I'm trying to say. I hope that that was helpful.
Okay, awesome. Well, great turnout. Thank you everybody for showing up. That was great. Any parting words, Jamie?
I just want to get people excited about this. This is a whole area that needs, they need us. I mean, they need us. I mean, if you look at how many pelvic floor clinics there are in your region, you'll probably only find maybe one. So it's a surefire way to help a lot of people very quickly. And I just hope that, you know, this was something that you can take back to your clinic tomorrow and maybe try it if you have somebody with coccydynia, and also just be open-minded to the type of techniques involved, because again, this renaissance movement that we're having right now, it is about the artist and the painting, and the needle is our paintbrush. It really is. It's every person that comes in is a new canvas, and you get to kind of paint however you want, and really make an impact. So, and I just want to thank you all for taking time out of your evening to hang out with us.
Yep.
Cool.
Awesome. Thanks everyone. We'll see you soon.
Okay, bye.
Bye.